Hello, my name is Richard Stone from Dana-Farber Cancer Institute in Boston, and we're here at the first international workshop on acute leukemias here in St. Pete Beach, Florida. We've just come from a session where we've heard about some emerging immunotherapies in acute leukemia. Some very exciting talks were heard, and we have three folks who gave those talks with us. Naval Daver from MD Anderson in Houston, who talked about checkpoint inhibitors in acute leukemias. Dr. DiPersio from WashU in St. Louis, who talked about very interesting preclinical data about using T cells to kill T cell leukemias. And Dr. Noelle Frey from University of Pennsylvania in Philadelphia, who talked about using CAR T cells to inhibit CD19 positive B cell malignancies. So very exciting days in medicine, finally using the immune system to kill acute leukemias. So let's start with you, Naval. Tell us about why checkpoint inhibitors may or may not be useful in myeloid malignancies.
Yeah, sure. So, the clinical data that we're seeing in the early salvage patients, salvage 1 and 2, is quite encouraging, which is, again, similar to other T-cell modalities, whether you're using blinatumomab or other T-cell engaging agents, because I think once you get beyond salvage 1 or 2, you really have wiped out T cells. So we're seeing 1-year survival in salvage AML, early salvage AML patients of 50%, which is encouraging. And now, of course, the frontline data, just as has been seen with most agents, when you move to the frontline, you get exponential improvement. So we're seeing about a 65% CR/CRi rate. I really think the key, though, is the management of toxicities, because we've been using these agents now for 2.5, 3 years. And I think now with the use of bispecific antibodies, CAR T cells, there's a lot of understanding about T-cell mediated toxicities that in heme malignancies maybe was not as well known as in solid tumors. We've used these agents for a long time. So I think as they go into phase 3, as you know, their phase 3 study starting looking at this, as well as randomized phase 2, I think the key is going to be whether we can identify and manage these immune toxicities, keep people on treatment for long term.
So there was a lot of concern about the use of these agents as single agents where the response rate seemed to be pretty low, but your data, as you pointed out, when you combine it with, let's say, a hypomethylating agent, the response rate seems to go up. Now, is that because you're doing something to the target cell, the AML cell, that allows the T cells to recognize it?
Yeah, so I mean, what we're seeing is if you look at the T cell profile in the bone marrow or in the blood, those who are already having high T cell infiltration, especially CD8 T cell by immunophenotype, not functional studies, are those who are responding much more frequently. So again, this is very similar to what is seen in solid tumor, that this does not work across the board. It's not maybe like venetoclax, but if you select the people who already have a T cell response, that's where you can get more bang for the buck. So I think really going forward, we're going to have to start using biomarkers, either T cell infiltration based or others, to select these people. Now, what it's responding to, that's something that I was just talking to Dr. DiPersio. I think there's now a lot of data emerging that although there are not true neoantigens, although nobody's really looked at it systemically, but given the number of mutations we have, I doubt there will be many neoantigens. There's a lot of aberrant expression. So you have WT1, MAGE, CTA. So I think what we really need to look at, and this is something we're doing on our responders versus non-responders, is to see if you can identify abnormal expression of antigens, either pre or post-transplant, that may be the targets.
So Dr. Daver is trying to make the patient's own T cells in the context of the malignancy work better, if you will.
Yeah.
Dr. Frey from Penn has got a different strategy. She's going to take the T cells out in patients with B cell malignancies and do something to them. So tell us the preclinical rationale for using chimeric antigen receptor T cells to kill B cell malignancies.
Yeah, so it's been very inspiring seeing some of the outcomes that we've seen with CART19 T cells targeted to CD19, which is the tumor antigen on malignant B cell ALL. And so the rationale for this approach was based on years of preclinical data supporting the idea that the patient's own immune system can be augmented to fight its own malignancy. And we're at a phase now with CAR T cell therapy where we've seen proof of the concept, we've seen success. And going forward, I think there's a lot of focus in the field of CAR T cell therapy to improve upon that success. And that includes using CAR T cells to not just fight CD19, which is such a perfect target, but to fight other antigens on the surface of the B-cell malignancy, and using what we've learned from our experience thus far to try and increase the durability of these remissions. So just a lot of exciting work to date, but also a lot more in the future to move the field forward.
Can you tell us, now there's actually one approved product in advanced B-cell leukemia. Can you tell us what the rationale for the approval of that product was and how it should be used today?
Absolutely. So there's a lot of different programs and platforms that have developed CART19 therapies for B-cell ALL. The first drug in this class was approved in August of 2017. It's the Novartis product, Kymriah. And the reason it got approved is that it was used in a multi-center, multinational trial for pediatric and young adult patients that had relapsed and refractory B-cell ALL. So it continued to show high remission rates, but importantly, it showed that this therapy can be applied at many different centers with central manufacturing. And the approval is based on the fact that historically outcomes in this subgroup of patients was so poor, and outcomes in response to this therapy was 81%. And so the approval went forward even though it was performed without randomized data, just because the improvement compared to how we think of this disease historically was so significant.
Now the approval's in second-line relapse, right?
Yep.
So how many people got the other approved agents in first-line relapse, such as inotuzumab or blinatumomab, and does it make a difference? Should I give my patient chemotherapy, then refer them to a place that can give Kymriah, or should I give them inotuzumab and then refer them or blinatumomab?
Yeah, I think it's a great question because we actually have the luxury of different choices now. We have traditional chemotherapy and other targeted agents. One of the approved agents in the United States for relapsed refractory B-cell ALL is, of course, blinatumomab, which targets the same antigen as CART19. And while there might be a logical inclination to choose something besides that to minimize the chance of antigen escape, like inotuzumab, which targets CD22, or even traditional chemotherapy. I think the important thing to remember is that the data actually doesn't show a higher rate of CD19 negative escape if patients have had prior blinatumomab, but we do have this luxury of choices. And so if the patient from another clinical perspective would benefit from any of these salvage therapies, I think the tendency is, if you're planning to do CAR T-cell targeted to CD19, is to try to avoid an agent targeting the same antigen.